right. Well, welcome everybody to our August primary care grand rounds. I have the pleasure today of introducing Dr. Emily Cedarbaum, who's going to talk to us about congestive heart failure. And I'll tell you just a little bit more about her, and then I'll pass it over. She grew up in Olympia, Washington, went to UW for undergrad, medical school, and master's of public health degree, then moved to San Francisco to continue her medical training at UCSF, where she did internal medicine residency, spent a year as a hospitalist, and then a cardiology fellowship, then advanced heart failure and transplant cardiology fellowship. 2 years ago, moved back to the Pacific Northwest and started working with us at Northwest Perm. She and her husband have an 18-month-old daughter, Mira, and a 12-year-old dog named Jasper. She enjoys being active outdoors with her family and friends, and primary clinical interests are advanced heart failure, heart transplant, and pulmonary hypertension. So with that, thank you so much for being here, Dr. Cedarbaum.
Thank you so much for having me. Can you hear me okay?
Yes.
Awesome. Well, great. Thank you so much for having me today. I'm really excited to talk with you about heart failure, my favorite topic. And you might hear that 18-month-old is here at home, and my husband's feeding her lunch. And our basement is currently flooded, so I couldn't go to our normal spot. So you might hear her eating lunch in the background. We'll see. So some learning objectives today. We'll review heart failure epidemiology. We'll outline ways about preventing heart failure, develop a framework for the diagnosis of heart failure, and discuss some evidence-based treatment for heart failure, both HFrEF and HFpEF, and I'll get into the distinction between those. And also we'll go over when to refer to cardiology, although of course we're always available to help whenever. For epidemiology, just a quick word on that. We are seeing rising heart failure hospitalizations and mortality. You can see on these graphs that both heart failure hospitalization and mortality rates have gone up over time. There's a little dip in the pandemic, partly because people weren't coming to the hospital as much for heart failure. So we are seeing those rates increasing. About a 24% lifetime risk of heart failure for the population in the US at this point. So about 1 in 4 of our patients will develop heart failure during their lifetime. We, of course, have to keep in mind racial and ethnic disparities as well as social determinants of health when caring for our patients in order to provide them with the best care. You can see the map on the left shows the highest areas of heart failure mortality from 2018 to 2020. You can see here in Oregon, we actually have quite a lot. Over in the dark red is the highest. And you can see the South also has a pretty high prevalence. The graph on the right side shows the excess age-adjusted mortality and life years lost. And this is where they took the rates in Black patients, subtracted the rates in white patients and graphed it here. So this is excess rates in Black patients. And you can see that not only are they much higher than in white patients, but the rates have increased over time. And so that's just something to keep in mind as we care for our patients, that there are a lot of social determinants of health at play here as well. For prognosis, the 5-year survival rate after a heart failure hospitalization is quite poor. I think that we all know this in theory, but it's helpful to see the actual rates, I think, because it's quite striking. These are, with a grain of salt, because these are patients who are 65 and over who are hospitalized for decompensated heart failure. But if you look on the graph or on the chart on the bottom here, the mortality rate for being hospitalized for HFrEF, HFpEF, kind of in between heart failure, is 75% over 5 years for patients who have had a heart failure hospitalization. And that's regardless of EF. So these are even our patients hospitalized with HFpEF and a normal ejection fraction. So overall, I think both in primary care and in cardiology, thinking about how to do prevention, really strong risk factor management and treatment is so important. So we'll start with the case. This is our patient, Miss A. She's a 63-year-old woman with a history of hypertension, prediabetes, breast cancer, who's coming in for her annual wellness check. Her blood pressure is 140s over 80s, heart rate is 70s. She's sitting well on room air. Her BMI is a little bit elevated at 27, normal exam. Her recently diagnosed with heart failure, and so she's asking, how can I reduce my risk of developing heart failure in the future? So we'll start with some information about prevention. And this, I think, is really relevant to the primary care setting, because this will be patients before they reach us in cardiology. So for patients in the primary care setting, managing hypertension is so extremely important. It's really kind of the cornerstone of preventing cardiovascular disease. So preventing hypertension, treating high blood pressure. In addition, you can see that healthy lifestyle habits are very important, such as regular physical activity, maintaining a normal weight, healthy dietary patterns, avoiding smoking. And you'll see kind of the color coding here on the screen. These are the ACC and AHA guidelines in cardiology. We are obsessed with them. They really guide our practice. And so throughout the talk, I'll be referencing the guidelines that we use to manage everything. And for pretty much everything in cardiology, if you look up ACC, AHA guidelines and type it in, the guidelines show up, and there are guideline documents for just about everything that we treat. Class 1 is the highest level of evidence, so things we really should be doing. Interestingly, in patients with type 2 diabetes and cardiovascular disease or at high cardiovascular risk, there are some strong studies about using an SGLT2 inhibitor to prevent heart failure hospitalizations. And here is one of the studies. So I'll dabble in some primary data, not too much, but this was a study where they took patients who are at high risk of cardiovascular events and had type 2 diabetes. They did Jardiance or empagliflozin versus placebo, and they found that patients had a statistically significant improvement with Jardiance for death from cardiovascular causes, any causes, and hospitalization for heart failure. So something to think about for our patients at a high cardiovascular risk. So she comes in the next year for her annual checkup. She was seen in urgent care twice in the last month for dyspnea on exertion and was started on some inhalers, but she's still pretty short of breath when going uphill, doesn't think the inhalers are helping all that much. She doesn't have any chest pain. Her vitals are stable. It's 93% on room air, but you notice on her exam that her legs are pretty swollen, 1+ lower extremity edema, and her JVP is a little bit elevated as well at 12 centimeters. Her labs are pretty unremarkable. Her basic labs look good. So I know that we don't have an audience response, but just to kind of think through it, what would be our next step for her? She's coming in with shortness of breath on exertion. So doing ultrasounds, a Zio patch, an echo, nuclear stress test, or genetic testing. So in terms of diagnosis, the guideline-based initial heart failure assessment includes an H&P, of course, so including a volume exam, so doing our best to look at the legs, see if they're swollen, looking at JVP to see how their volume status looks, and then taking a family history. You know, if they say, oh, everyone in my family has had heart failure by the time they're 40, then that really guides us in a different direction than if there's no one in their family with heart failure. A 12-lead EKG, and then getting basic labs, including iron studies and TSH, and then BNP. BNP can be really useful in patients who are coming in with dyspnea. It can help to decide, you know, if it's elevated, this patient, you're thinking, okay, my spidey senses are up about heart failure. They have an elevated BNP, and we're using an NT-proBNP at Kaiser, which is great. And then if it's low, it doesn't necessarily rule it out, but it kind of reassures you that, okay, their BNP is not elevated. Maybe I'm going to think about other things as well. This is a diagnostic algorithm for suspected heart failure. It basically just puts in a picture of what we just talked about. So your H&P, getting a BNP, an echo, and then this is the division between HFrEF and HFpEF. HFrEF is technically 40% or lower on the ejection fraction, and HFpEF 50% or higher. This mildly reduced, or HFmrEF, is 41 to 49%. And it's a little bit of a gray area because there's not a lot of studies on this patient population. Most of them are on HFpEF or HFrEF, and most of us just end up kind of treating that middle area similar to how we do for HFrEF. So for diagnosing heart failure, the echo is really key. It will guide you in one direction or another. For the guidelines, it does recommend getting a chest X-ray as well. And the echo can be done during the initial evaluation to see how people are doing and if they have heart failure. And it can also lead to so much more information. An echo just is a wealth of information. Sometimes people end up getting diagnosed with severe aortic stenosis or some congenital abnormality or amyloid, or, you know, the echo is just so helpful in figuring out what's going on with their heart. So the echo is helpful both to diagnose heart failure. If there's a clinical change, like you have a patient who is on heart failure therapy, but is suddenly getting worse or something, they're getting something, some new symptom, it can be helpful. And then we always check an echo after a few months on medical therapy for heart failure, which I'll get into in a little bit later. But I just wanted to bring up the point too that there's no benefit to getting routine screening echoes. Like there's no follow-up and echo in a year or something like that for heart failure. If there's no clinical change, if you're not going to be doing anything different because there's nothing that's been changed. You haven't changed their medicines. They're not being considered for some new device. There's no need to just get routine echoes at certain intervals for heart failure. So the next step would be to get an echo for her. And on her echo, you find that the ejection fraction is reduced 30 to 35%. Her RV is a little bit reduced. Her valves look fine, and her IVC is greater than 2.1 centimeters and less than 50% collapsing with inspiration. And that's a sign of volume overload. So the IVC is kind of a marker of the right atrial pressure. And if it's elevated, then you worry about fluid. So you get some labs for her. The BMP is normal. CBC is normal, except that the hemoglobin is a little bit low. Her NT-proBNP is high, and she has low iron. So some common causes of heart failure. I, in my mind, like to split this in between ischemic and non-ischemic causes. So a lot of times in our notes, you'll see ICM and NICM for ischemic and non-ischemic. This is just a dramatic STEMI EKG, but it kind of guides you in different directions for how they're managed and treated, although the medications are the same. So for patients who have ischemic cardiomyopathy, you often end up knowing the cause pretty soon, but for non-ischemic, it can be many different causes, hypertension, valvular heart disease, and then this whole list of other things that it could fill multiple slides. There's so many different things that can cause heart failure, genetic cardiomyopathies, amyloid, cardiotoxic meds. We see a lot of patients with methamphetamine cardiomyopathy or alcohol-related cardiomyopathy, patients who have pacemakers that are pacing the right ventricle just 100% of the time. For those patients, they can end up with it. Stress cardiomyopathy, peripartum, inflammatory problems like myocarditis, and many more. And the way we describe heart failure, I just wanted to get into the language of it a little bit. I generally in my notes try to put a stage of their heart failure and then a symptom class. So for the stages, just briefly, the stage A patients are patients that don't actually have heart failure, but they're at risk for it. So they have high blood pressure, diabetes, obesity. I feel like most people are probably in stage A. Many people are at risk for heart failure. Stage B is patients who have structural heart disease. Like if they got an echo for some reason, it might show that their EF is a little bit reduced, or someone got a BNP and it's a little bit elevated, but they don't have any symptoms, so they don't have clinical heart failure yet. Stage C is the majority of patients that we see for heart failure. These are patients who have structural heart disease and who have signs and symptoms of heart failure. They're coming in with shortness of breath or leg swelling. And then stage D is advanced heart failure, patients who have progressed beyond stage C, who have not responded to treatment and are needing to be considered for more advanced therapies like heart transplant. The NYHA classes are the symptoms of heart failure. So patients can go in between these all the time. And it's just helpful to kind of classify them in these classes. And it's often how they're described in studies too, for which patients are included. So NYHA class 1, someone has no limitations. 2, they have some symptoms with ordinary activities. 3 is less than ordinary activity, they have symptoms. And then 4 is usually people who are short of breath at rest. So for our patient, Miss A, staging and classifying her, she's short of breath when going uphill, but she was okay on flat ground, and her EF is reduced. So she would be stage C because she has structural heart disease and symptoms, but she hasn't tried any medicines yet or anything, so she's not advanced. And then NYHA class 2, because kind of ordinary activities like going up a hill is making her short of breath, but she'd be okay walking around at the grocery store. So for diagnosis and next steps, the initial diagnostic workup includes the H&P, the labs, EKG, and an echo. And a lot of times from there, you'll be able to kind of find out sort of an etiology. It might not be confirmed, but if someone has a wall motion abnormality, you might be thinking of ischemia. If their EKG shows like Q waves, then you're thinking of ischemia. So it'll start you thinking about the etiology, and then you can start medical therapy. And then I'll get into this more in who should be referred, but I think that most patients with HFrEF or reduced EF should be referred to cardiology, and that's because many of them need an ischemic workup. Many of them we end up sending for a cardiac cath or a coronary CT. There's other considerations like whether they should get a cardiac MRI. There's a lot of newer evidence over the last 5 years about the benefit of AFib ablation and really rhythm control for patients with AFib and HFrEF. So getting them into electrophysiology to think about that. Things like primary prevention ICDs, cardiac resynchronization therapy, advanced therapies. And then we also have a heart failure case management program where patients get enrolled with the nursing team and they're able to up titrate their medications over the phone. And so that's really helpful and a nice program to access through cardiology. So what do you start next for our patient Miss A who has an EF of 30 to 35%? Do you do Hydral and Isordil, losartan, metoprolol tartrate, diltiazem, apixaban? So to get into our treatments, some non-pharmacologic treatments, and these are also in the guidelines. Things like multidisciplinary team care, so including primary care, cardiology, social work, et cetera, is helpful. And then education, of course, screening for things like depression, frailty, health literacy, social isolation, exercise programs and cardiac rehab, and then reducing dietary salt intake is helpful. There's less evidence for reducing fluid intake, doing a strict, we shouldn't have our patients drinking like gallons of fluid every day, but a very strict fluid restriction is very hard for people to adhere to, and generally they don't. And so there's, especially in the hospital, like from hospital to home, if we restrict them too much in the hospital, then we're not getting the right diuretic dose for when they go home. So I usually try to restrict salt intake, but I'm not as strict about saying you can only have 1 liter of fluid or something like that. I just wanted to bring up this overall roadmap of treatment for heart failure. The part on the right, so kind of step 4 and on, I think is not very relevant to primary care. I think that's really like within cardiology clinic. We should be thinking about ICDs, heart transplant, things like that. But the part on the left here is definitely stuff that we can work as a team together to do. So these are the medical therapies for patients with HFrEF. You can see, and we'll go through each of these. That we can see our 4 big pillars of heart failure medical therapy, and a part that I think is really easy, or not easy, but relevant to get started in primary care too, is diuretics as needed. So patients who come in volume overloaded, they can really be helped by getting on some Lasix, some Bumex or torsemide to help them feel better as we start getting their medical therapies going. And these are all class 1 indications. So green is class 1. It's what we really should be doing. 2A is we should, unless there's a good reason not to. So this chart basically focuses on our class 1 indications. The 4 pillars of heart failure medical therapy, this is really what we do all day, is try to start patients on these medical therapies. And the reason why we're so obsessed with it is because it reduces morbidity and mortality for patients with HFrEF. It is a lot of medicines. So I usually counsel patients up front, like, hey, it's a whole new thing. You're going to be on a bunch of medicines, and it's going to be kind of hands-on. That's why we get you up titrated on them. It's going to feel pretty different for a lot of patients who are not used to being on a lot of medications. And they have to come in and get labs, and they have to take their blood pressure. But overall, it's not to, bug them. It's really because they are very evidence-based for improving morbidity and mortality, reducing heart failure hospitalizations, improving the ejection fraction on patients with heart failure. So we are.
Question, sorry to butt in. We're hoping you can, when you go through these medications, to just touch a little bit more on Entresto, as I think we're wondering if that's something that we should be thinking about more in primary. care in terms of prescribing.
Mhm.
So that would be great to also chat about that a little
Yeah,
bit.
happy to, happy to. Um, yeah, I think the one thing I'm not sure about is whether because some of these medicines I know that they only show up when cardiology types them in. So I don't know 100% for sure if it shows up for non-cardiology when you type it in.
Yeah.
I think it
In our
should.
chat too. Yeah, it looks like we're noting that you have to have a cardiology consult before prescribing it. Um,
Okay.
but yeah, that'd be still be awesome to hear a little bit more about it too.
Definitely. Yeah. Yeah. I would love to. And I have a slide coming up on Entresto and some of the studies behind it too. I love that question. So these are, our four pillars. So the ACE, ARB, ARNI, and sometimes people in their note, like the way that I put in my notes, I actually just write down each of these categories in my plan because I want to make sure that I'm not forgetting one of them. Some people do that. Some people put kind of preload, afterload contractility and write down what they would do for each thing. So whatever works for you. I've kind of transitioned to just writing down these names so that I remember to start each of these things. So ACE, ARB, and ARNI, we've got lisinopril, losartan, and Entresto, and really any of them. I just wrote some example names here. For the beta blockers, these are the evidence-based beta blockers for heart failure: methotrexate, carvedilol, and bisoprolol. So the other beta blockers have not been studied or have not come out to be beneficial for heart failure. These are really the evidence-based ones. So for patients who are already on like metoprolol tartrate, I generally try to switch them to metoprolol succinate. Or if they have a lot of blood pressure room, I'll try to do carvedilol because it has more blood pressure impact than metoprolol. Um, and then patients who have side effects with metoprolol and carvedilol, bisoprolol is one that kind of crosses the blood-brain barrier a little bit less and can help patients who have that kind of dragged down, tired feeling from beta blockers. The MRAs are spironolactone and eplerenone. Generally, we have to try spironolactone, and if someone has a side effect from it, like gynecomastia for men, then they can get eplerenone, but they have to have I think they have to have failed in our system spironolactone before they can get eplerenone. And then SGLT2 inhibitors, for us, it's empagliflozin, which is Jardiance. Other ones are dapagliflozin, there's canagliflozin, anything that ends in gliflozin. But Jardiance is the one in our system.
Are there certain
Um,
ones that maybe you'll touch on this too, but if we have patients with like hypotension or renal disease where we are worried about dropping their BP too much, like are there certain ones that you'd really emphasize or that have more benefits than others?
That's a good question. It's definitely patient dependent, and um, there's no guideline or exact formula for like what order to start these in and what to do first, what to do second. So I generally, I try to get a beta blocker on, and because it has a big impact on remodeling of the heart. So I do try to get a beta blocker, even if it's a low dose. Like you don't have to start at something high. I often start at like metoprolol succinate 12.5 daily. In these patients, that's very low dose, and that shouldn't impact the kidneys. And similarly with things like losartan, I'll start really low, like 12.5 daily, something tiny, and just see if they tolerate it and up titrate it from there. The important thing is to get them on all the meds. It doesn't have to be like in 2 days they're on super high doses. It's really over time. And Jardiance, unless they're on dialysis or peridialysis, it's generally okay to use. And it does help with fluid removal as well. So a lot of times when I'm starting Jardiance, I'm able to decrease their loop diuretic. Like if someone is not very volume overloaded and I start Jardiance, I'll often cut their loop diuretic in half. And so that can help with managing the renal function. If their renal function is really bad, then I think that having cardiology do this in like with nephrology is totally reasonable. And we do have like that heart failure nursing program that can help with monitoring everything. But yeah, I think that in terms of people who have lower baseline blood pressure, just starting low is what I usually do. And even 12.5 of metoprolol is better than 0 of metoprolol. And the overall goal is really to up titrate to target doses or the maximum tolerated doses. So I think that's the key, is that many patients are not going to reach. I just put an example down here of the beta blockers. Many patients are not going to reach 200 a day of metoprolol. Like that is a high dose. And it's great if they can be on it, but many patients won't get to it. And so it's really just what is the highest dose that they can tolerate with their blood pressure, their kidneys, their symptoms. Um, and you can titrate pretty quickly. So like the guidelines on the right here, you can see that you can titrate like every 1 to 2 weeks, depending on their symptoms. And I also understand that can be very challenge, it can be very time consuming. And so I think that's one of the things, even for us in cardiology, like if I have patients getting up titrated on this, it's hard just as me to be doing this through kb.org messages and calling the patient. It's very, you can't really logistically do that each day for all of these patients. And so having some help from a nursing team is great.
Sarah, if you want to go ahead with your question.
Yeah, hopefully I don't have too much of an echo here, but I probably need to speak to my headset. Can you guys hear me?
Yeah.
Okay, so in the case, this kind of builds off of what you were asking, Toby. Let's say you had a patient on all of the goal-directed heart failure therapy, but then they're coming in hypotensive or very low blood pressure. What's the first medicine that you pull off? And so I try to rank them in my mind, like what is providing the most mortality or symptom benefit. And I always struggle, should I be pulling off the Entresto? Should I be pulling off the obviously you're going to titrate the diuretics, and if they have AFib, you're probably not going to leave the beta blocker alone. But when you're thinking about like the ACE, the ARB, the Jardiance, what are you pulling off first?
It's a good question, but a hard question because it's so patient dependent for each person. I would say that if someone has a lowish blood pressure but is not symptomatic, even if their blood pressure is like 80s or 90s systolic, we are fine with that. If they're not symptomatic, it's okay for them to have a blood pressure of like 90s over 60s, as long as they don't feel dizzy. Many of our patients with heart failure with a low EF will have that kind of blood pressure, and it's okay. I know it doesn't feel great, but it's okay as long as they're not symptomatic. If they are symptomatic, then I would first see their fluid status. Are they volume overloaded? If not, if they're not volume overloaded, then the first thing I would peel off is the diuretic, because that doesn't have additional mortality benefit. Like being on Lasix doesn't have, it's really symptomatic benefit and helping them feel better. So if they're not volume overloaded or if they're dry, that can be made as more of an as needed kind of thing. But then if they need the diuretic and their blood pressure is low and they're dizzy, then you're probably not going to get very much blood pressure improvement from taking off a low dose of spironolactone, because that doesn't impact the blood pressure that much. And similarly with Jardiance, it doesn't have much blood pressure impact. So if possible, to not take away the ACE or ARB or beta blocker, but just decrease the dose. That's what I would do. If they're on a super low dose already, then you're a little bit stuck. But if they're symptomatic and they're hypotensive, then you have to take them down a little bit, unfortunately. So I think I think Jardiance and spironolactone don't have that much blood pressure impact. The diuretic is not necessary for GDMT, it's more for their volume. And if you have to reduce the dose of a beta blocker or the ACE ARB ARNI, then you have to. Because ultimately we want our patients to get better, but we don't want them to be passing out. Does that help? Cool.
Yes, thank you. My patient was 70s over 30s, so I definitely had to pull something off.
Yeah, I'm fine with the 80s, but once it gets to the 70s, I get worried, especially if it's an older patient. So I just wanted to go through a little bit of the data for Entresto, like we were talking about before. One of the core studies for Entresto is called Paradigm HF. It has an interesting study design where they kind of put everyone on an ACE inhibitor, and then they switched all the people to Entresto, and then they randomly split them into ACE or Entresto. And so they did this kind of double-blind run-in design, which ended up being a pretty interesting study and very useful. And you can see this was before Entresto even became Entresto. So it was this LCZ 696 is Entresto. And this basically showed that using an ARNI, so Entresto, is better than using an ACE for reducing heart failure, death, heart failure hospitalization. And so in general, we do try to switch patients from ACE and ARB to Entresto when we can. something to keep in mind is that an ACE inhibitor has to be held for 36 hours before you start an ARNI like Entresto. That's because of that interaction there. So 36 hours is an awkward time period. I usually just do 48 because otherwise it's a little confusing, I think, for people. And so that has to be held, but you don't have to hold for an ARB. So like losartan going to Entresto, you don't have to hold it. You just do the next dose, you go to Entresto. And that's why I think generally you'll see most of us starting losartan now. It's instead of something like lisinopril. It's not because losartan's better than lisinopril. It's just that it's easier to transition to Entresto. The hold is just a little confusing, I think, for a lot of people. And so it's a class 1 indication in our guidelines that for patients with symptomatic heart failure who tolerate an ACE or an ARB, switching to ARNI like Entresto is better to improve morbidity and mortality. So where we can, we try to switch them over. And there's those 3 dose levels of Entresto, which makes it kind of easier to dose than something like all the others. There's so many different doses you can choose. Entresto, there's really just 3. There's 24-26, 49-51, and 97-103. And if they're on a lower dose of an ACE or ARB, you just start at the lower dose of Entresto. If they're at a higher dose of an ACE or an ARB, you start at the middle dose, the 49-51. And the company website for Entresto has like the doses that they consider high and low. So I'm always looking to see if this patient on, ramipril, what is considered a low or a high dose of that for which Entresto dose to start with. And then for SGLT2 inhibitors, Emperor Reduced is the trial. There's also one for dapagliflozin, which is DAPA-HF. This basically showed that Jardiance lowers the risk of cardiovascular death and heart failure hospitalization. And that's regardless of diabetes. So it doesn't matter if the patient has diabetes, they should be on Jardiance, just not in type 1 diabetes. So that's also a class 1 indication to improve morbidity and mortality in patients with heart failure. Here are those evidence-based beta blockers that we were talking about. And one caution is if someone is very volume overloaded, it's better to wait a little bit to start a beta blocker. That's because the beta blockers kind of reduce your contractility in the shorter term. And so patients who are very, very volume overloaded can end up more volume overloaded and even going into shock if you start a bunch of beta blocker up front. If they're euvolemic or even a little bit hypervolemic, that's fine. But if they're like super swollen, I would wait to get them more euvolemic before starting a beta blocker. And it's fine to start low and up titrate. I start super low on these. I don't want anyone to have a bad side effect and stop taking it. I'd rather start low. Some harmful drugs in heart failure are the non-DHP calcium channel blockers, so like diltiazem, that's harmful in heart failure. Things like flecainide, NSAIDs, and some of the other diabetes medications. So the answer would be to start losartan for this patient. And the metoprolol is not right because that was metoprolol tartrate, and succinate is the evidence-based one. So just a reminder about our little graph here, and I think that the slides are provided to you. So, and this is also just in the guideline document. I just like the schematic here. So now she's on full dose guideline directed medical therapy. She feels much better. She's not had any heart failure hospitalizations. She has no CAD. Her genetic testing is negative. And her labs are all pretty normal, including her NT-proBNP has normalized, which is a great prognostic sign. But her iron is pretty low still. That's the only abnormal lab. So what can you do to help improve her quality of life? Give her oral iron, IV iron, tell her to eat more spinach, give her more loop diuretic, or give her a heart transplant. And the studies show that IV iron is actually very helpful for patients' quality of life. I really love doing this because it's like a low harm, easy intervention, and people genuinely do feel better. Afterwards, they notice an improvement in quality of life. So for patients with a low ferritin or a ferritin between 100 and 300 and a TSAT less than 20%, those were the ones included in the studies. And it's regardless of anemia. I don't do this for patients who have a high hemoglobin, like above normal, but it's okay if their hemoglobin is normal. And on the right here, the graph is for the Kansas City Cardiomyopathy Questionnaire, which is a quality of life questionnaire for how they're feeling. And this does not hold up with PO iron. So the studies have shown that doing oral iron repletion does not have the same benefit. So I think giving a dose of IV iron is a great way to help people feel better who have heart failure. So that's the answer is the IV iron repletion. And I just wanted to do a quick word on stage D heart failure. Hopefully, we're not dealing with too many of these patients in primary care without cardiology helping. But these are patients who have tried medical therapy and they have not improved and they're not feeling well, and they should be considered for advanced therapies or palliative care. So it's if it's a younger patient, we should certainly be thinking about heart transplant or LVAD. If it's 90-year-old patient, they're not going to qualify for one of those things, and we should be thinking about palliative care and supporting them in dealing in getting hooked up with hospice and things like that. And the reason I bring it up is because if we don't think of it, patients are referred too late, and there's a lot of data about patients who are just being referred when things are really, really progressed and really, really bad. And then you're in a tough spot because they might be too sick for something like a heart transplant or an LVAD, and you've missed your window. So just something to have in mind if you have a patient like this who's really not thriving on medical therapy and not doing well, thinking about, is this someone who should see the advanced heart failure team? There's this acronym that I think is a variable help because I think that it's commonly used now. It's a great acronym for referring to advanced heart failure, but I just think that they really tried to make it finish this "I need help" thing with the way that the letters are. So these are just keys that should make you think about it referring to advanced heart failure. If you have a patient who's being hospitalized all the time for heart failure, if you're really having to escalate the diuretics, their blood pressure is super low on medical therapy, you're not able to up titrate, they're on an inotrope, they're NYHA class 4, things like that are people who should probably be establishing with advanced heart failure, unless there's some good reason not to. If they're actively using meth, they're not going to be a candidate for advanced heart failure therapies. If they're 95 years old, then maybe the goals are a little bit different, but just ideas about when to have a heart failure specialist get involved. So 3 months after achieving her goal doses, the echo shows her EF is normal. She's now NYHA class 1, and she's saying, I'm taking a lot of medicines. Could I get rid of some of these? I'm feeling so much better. My heart's better. What do you tell her? So yes, she can come off with close monitoring with echoes. No, she shouldn't stop it, or some combination of stopping certain ones but continuing others. So overall, the key is try not to stop GDMT if you can. The diuretic is totally fine, like we were talking about. It's fine to stop that. That's just for symptomatic management and helping them feel better and stay out of the hospital if they're volume overloaded. But those 4 pillars, unless you have to stop it, like for your patient whose blood pressure is 70s over 30s, unless there's something like that, then trying to continue it if possible is the best route. And our studies do show that patients where it's stopped, even if they're asymptomatic, even if their EF is improved, that have improved EF is heart failure with improved EF, people have relapses much more often than if you continue the GDMT. So continuing it is the way to go if you can. So no, she should not stop it. So some take-home points. I'll be a little bit quick, I think, because I think I'm running a little short on time. But in patients with suspected heart failure, getting an echo and a BNP can be very helpful to figure out, is this patient having heart failure or is it something else? Describing heart failure with the ACC-HA stages and NYHA class, starting GDMT and titrating to your target doses with the 4 pillars of heart failure therapy, repleting iron with IV iron, and then generally referring to cardiology for ischemic evaluation, arrhythmia management, whether they need an ICD, help with up titrating the GDMT, because we do have some resources to help with that, and considering things like advanced therapies. So our case 2 is Miss C. She's a 63-year-old woman with hypertension, diabetes, AFib, obesity, and she's coming in for her annual wellness check. She's really motivated to start an exercise program, but she feels a little short of breath with exertion and has noticed some mild lower extremity swelling. You get your echo and BNP, and your BNP is elevated. The echo shows normal EF, normal RV, no valve problems. The IVC, though, is large and non-collapsing, so you have a sense that she might be fluid overloaded. And then her BNP is elevated, which also helps you confirm that. So we're moving on to HFpEF. HFpEF is where the EF is greater than 50%, and there's evidence of increased LV filling pressures. And this can be any number of things, like an elevated BNP. If they have an invasive measurement, like if they were to get a cath, the LV EDP or the end diastolic pressure would be elevated. Sometimes it's with exercise only that you see that go up, and that still counts as HFpEF. And then one thing that I actually use a lot that I like is for patients with dyspnea and a normal EF, this HFpEF score. If you just Google it, the different calculators come up, but it can give you a sense of the probability that your patient has HFpEF. And you can see also the risk factors for HFpEF on here. So elevated BMI, hypertensive, if they have AFib, if they have higher PA pressures on their echo, if they're older, and then if the filling pressures on echo are high, you can get a sense of whether that patient is likely or unlikely to have heart failure with preserved ejection fraction. And I think one important thing for HFpEF is that there's a lot of kind of less common causes. It's a big bucket of things that can cause HFpEF. Most patients, it's going to be hypertension, AFib, comorbidities, that kind of thing. But there are patients that have things like cardiac amyloid, sarcoid hemochromatosis, HOCM, different genetic disorders. And I put an amyloid echo on the right here. And really with things like amyloid, the echo should alert you. If someone's reading the echo, like if I'm reading an echo and it looks like amyloid, I'll put that in the read. And so I think just keeping in mind that there are these, if it's a little bit weird, like if it doesn't quite fit that this patient who's not even hypertensive and seems fine has HFpEF, then I think it's good to consider these other causes. And just to remind us that prognosis for all heart failure, including HFpEF after a hospitalization, is poor, and so treating and preventing is super important. And for treatment, we have a big focus on HFpEF comorbidities. So whereas for HFrEF, we've got our GDMT, we're like, okay, I've got my 4 pillars, I'm going to do this thing. For HFpEF, it's really like a whole system thing. Think about all the different risk factors for HFpEF that we can control. So things like hypertension, coronary disease, diabetes, CKD, sleep apnea, obesity, AFib. These are all kind of intertwined with HFpEF. And for managing it, it is the most important thing is to manage the underlying conditions. Exercise training has been shown to be helpful. And then for treatment, medication-wise, diuretics are really the only class 1 indication. So patients benefit from being on Lasix. A 2A indication that I think might become a 1 in the next iteration of the guidelines we'll see is the SGLT2 inhibitors. And so we talked about Emperor reduced for HFrEF. Emperor preserved is the similar study for SGLT2 inhibitors, but in HFpEF. And it showed that SGLT2 inhibitors, regardless of diabetes, improved cardiovascular death and heart failure hospitalization as a composite outcome. This was really driven by heart failure hospitalization. It didn't have that much impact on mortality. It was more heart failure hospitalization, which is still really important to reduce hospitalizations for patients with HFpEF. So I do try to get my patients with HFpEF on an SGLT2 inhibitor. The trial for MRAs in HFpEF is called TopCat, the original one. And initially it didn't show that there was any benefit, but then they found that there were kind of 2 groups. There was a study population in Russia and a study population in the Americas. And when they separated them out, post-hoc analysis is always a challenge, but they found that the study population in the Americas did have some benefit with spironolactone, and the study population in Russia did not. And it's brought into question whether the patients in Russia were being given the medication accurately, because when they tested some of the patients, they didn't actually have spironolactone metabolites. So it's a little bit of a challenging study to interpret, but spironolactone is helpful for fluid removal and for keeping the potassium up, and it's probably helpful. So I often add it on for my HFpEF patients. And I wanted to bring up GLP-1 agonists as well. I know it's a big hot topic right now, and that GLP-1s have shown benefit for patients with HFpEF for improving their symptoms, their exercise function, and improving weight loss. It's, of course, an area of active research right now. There's a lot of studies on this, but there's a great study for HFpEF that came out in 2023, and you can see the graph here that it did improve. I just chose the graph for the KCCQ, which is the quality of life questionnaire. People do feel better on it, people with HFpEF. So it's nice to be able to use that medication for them. So some take-home points. HFpEF is EF greater than 50% with evidence of increased LV filling pressures. And most important to manage the underlying conditions. Using diuretics, Jardians, and probably an MRA is great. And then GLP-1 receptor agonists are showing benefit as well. And then keeping in mind in the back of your head, there's these less common causes of HFpEF if the patient doesn't quite fit, like amyloid and HOCM. And then last slide is when to refer patients with heart failure to cardiology. HFrEF, I would say refer most patients. We can work together in partnership with you to up-titrate these medications. And many of the patients do end up needing things like a cath or referral to EP. So I think we can all work together on those patients. For HFpEF, I would say if you can address comorbidities like getting their hypertension under control, their volume status, starting things like Jardiance, and then if they're still having symptoms when they're euvolemic, or if it's really hard to remove the fluid, or if you're worried about other etiologies, definitely feel free to refer to cardiology. Or if it's just if it's a hard case, we're always happy to help and see these patients. And I think a plug for cardiologists of the day. I think I've met many of you that way. When I'm sitting there answering messages, we're always available to discuss cases and guide appropriate referrals and help with this. If you're wondering, if your patient's hypotensive and you're wondering which GMT medication to decrease, like we're a resource for that. So feel free to reach out. We're happy to help. And thank you so much. I went a little quick through that last part because I realized the time was running short. So I'm happy to answer any questions, and you are also welcome to email me or Teams me or anything. And I'm happy to be a resource. So it's been great talking with you today.
Thank you so much. And remember, folks, too, this is recorded if you have to pop off. But maybe a couple questions that came through in the chat just now. One was, and I think more related to heart failure with preserved EF, whether it's helpful to trend the NT-BNP.
So there's not as much evidence for trending it, although I do find that it can be helpful in clinical practice. Like I don't think you need to get it all the time. Like if you see someone who's clearly volume overloaded and you already have an elevated NT-proBNP, you don't necessarily have to get another one to show that it's still elevated. But if it's been normal before and then you get one that's elevated, that can be helpful. Sometimes with HFpEF, it's not elevated and they're still volume overloaded, so it can be a little bit confusing. But I personally do like to get it, if there's a clinical change, I'll get it. Or if I'm starting a diuretic and then checking electrolytes a week later, I'll often do it with a BNP.
Thank you. And then another question that was, I think you'd mentioned how you're recommending exercise for HFpEF, and folks are wondering if there's any specific type of exercise, whether strength, cardio, balance, like any more set recommendations.
Oh yeah, I have to look and see if there's specific evidence on the exact exercise regimen. But what I usually tell people is it's good to do an aerobic exercise for 30 minutes a day, 5 days a week or so if they can. And that can be walking. But overall, my biggest thing that I tell patients is find something you enjoy doing because then you'll do it. If someone hates running, I'm not going to tell them to exercise by running. So whatever they enjoy doing, that's the best way to exercise. And if that can include 30 minutes of aerobic exercise most days, that would be ideal.
Sounds great. If anybody else wants to chime in too with questions as well, or there's probably some in the chat that we didn't get to, feel free to jump on if assuming you have a couple more minutes, Dr. Cedarbaum.
Let me see if I can figure out how to go to the chat. Let's see, I might have to stop sharing to see it.
I can read another one here in the chat. Dr. Delgado is asking, it'd be really great to not have to figure out if IPV is indicative of fluid overload. Is there a reason why the reviewing cardiologist can't say echo consistent with or suspicious for heart failure with preserved EF?
What is IPV?
That's what I was wondering as well.
Do you mean IVC? Okay.
IVC, okay.
Okay.
Okay,
I was like, I think IPV is interpersonal violence.
Yeah.
So let's see. Is there a reason why they can't say echo? I think that it's hard because HFpEF is a clinical diagnosis, so I think it's hard. Like I'll usually say if I think it looks like amyloid or HOCM, but I think it's hard to say it looks like HFpEF because it's such a clinical diagnosis. But I think like maybe we could say, I think I'm trying to think if in the echo software if it ends up saying elevated for IVC, because if it's consistent with RA pressure of 15, that's elevated, but I'm not sure if it says elevated. I can't remember. I can look and see if it does, because that could be a nice thing to add in, that at least it would mark if it's high or not, because I know that not everyone is looking at IBCs all the time like we are.
Anything else on folks' minds? I know a lot of people have to jump off to clinic. Well, thank you so much. We really appreciate you coming to talk with us.
I'm happy to. No problem. Thank you for asking me to.
Yep. Take care.